As first, you have to restore the hemodynamic stability of your patient. So give fluids in a wise way, let's say. So you can be liberal, but it depends on the patient that you have. Immediately thereafter, if this is not enough, try to give some vasoactive agents and assess the cardiac and the vascular function with some of the tools, those you have in your hands, on those you are able to use at the best. Then immediately start the antibiotic therapy together with the source control, and if surgery is necessary, is a fundamental having the collaboration of other specialists to remove the focus of infection. For the continuous assessment, you need to reassess and reassess, and you may look at the lactate as a good indicator for the evolution over time when they are higher. For all, there are other recommendations at the very end. Is not so different from the one that we follow in our everyday clinical life, like for the application of the protective ventilatory strategies as soon as you have respiratory failure.
Just one final comment, perhaps,
yes.
And I'm sure we would agree. I mean, it's important to make the difference between a recommendation and a
yes.
suggestion. A recommendation is something normally that you should apply in all the patients. If you deviate, you need to have really a very good reason to explain to your boss the next morning when you go to the unit, or to the lawyers when you go for the court. A suggestion is something that is better to do, but you may have good reasons not to do, and if you don't do it, you cannot be suited in front of a tribunal at the end of the day. So I know that we discussed this with some of our American colleagues in terms of even reimbursement of other issues like this, and more than reimbursement is really the care of our patient, which is important behind this, and it's important to really make the difference between suggestion and a recommendation.
I think that the legal pressure is very high everywhere nowadays in any country, and that is why we should have to keep in our mind always this important differentiation. Thank you. You are, by the way, one of the authors.
I know. I know, put you on fire several times. So thank you very much again, and we go for the last presentation, but not the least one, because we will discuss sepsis and the elderly, and it will be Shigeaki Inoue from Japan who will discuss this.
Okay, good afternoon everyone. So it's a previous two very nice clinical presentation. We are moving to the elderly problem in sepsis. Actually, we are focusing on immunology. Elder has a lot of the problem, but I'm an immunologist as well as I see doctors. So my talk today is a little basic immunological issues in elderly. So as you know, aging in Japan is a huge problem. 30% and 35 million people will be over 65 years old in the 2030. But not only Japan, the aging is a whole wide problem. As you can see, 2008, only some European and Japan countries are the aging country, which is over 20% of population over age 65. However, it will be expand the whole the world except Africa and Mid-East Asia. And sepsis is known as a disease of the elderly because 60% of the patient and 80% of the death due to sepsis comes through over 65 years of the age. So based on the aging problem, so my own lab concerning the immunosenescence has several works. For example, the reduction of the immunocompetent T cells and the T cell exhaustion, and less of the lymphopenia and delirium. And we also focus on the B cell dysfunction in the elderly septic patient. So summarized in these papers, so when we think about the elderly patient, we have two insights. The first is aging itself. So aging loses the number of the CD8 T cells, and some part of the inactivate of the T and CD4 and the CD8 T cells. And the infection due to the sepsis will reduce both the functional and numerous loss with increased PD-1 regulatory T cells and memory markers. So Sepsis is a kind of the HIV infection, with a loss of the function and the numbers, but especially in the CD4 T cells. But this study is still incomplete because we have just checking on the expression of the surface marker of the CD4 and 8 T cells. So we see that all the function, how did the aging affect the activation, how did it lose the production of IL-2, which is a growth marker of T cells, and proliferation, and how it affects the secondary infection and death. So the purpose of the study is to investigate the relationship between the T cell exhaustion and secondary infection in aged patient after sepsis. So we conducted a 1-year prospective study in our hospital, and finally so we took the blood from 55 patients and the cohort with our same donors. And we took the blood and within the 48 hours after sepsis diagnosis, we have measured cytokines and conducted immunoanalysis by the flow cytometers. So age was divided into 2 groups by 65 and young adult sepsis and elderly or elderly septic patient. And we cultivate the PBMC from a lymphocyte, basically a lymphocyte, and activate CD3 and CD8, check the activation, IL-2 production, and the proliferations. Here's a summary. So actually, there's no different characteristic in elderly septic patient and aged septic young patient. And the SOFA score is higher in the elderly patient, young patient. However, impaired activation of T cell was observed in severe sepsis in the elderly patient. As you can see, our healthy donor can activate easily, like 65% with stimulation. However, adult sepsis and elderly sepsis patient is highly impaired with activation. And so elderly patient cannot produce the IL-2 in the supermuscle. We have the 24 hours incubation of the stimulation of the CD4 and 8 T cells. So this shows the impaired IL-2 production in severe sepsis in the elderly patient. So 24 hours incubation is not enough, so we have continued 3 days to see the proliferations. So we cultivated the, some cytokines with CD3, CD8, and see the proliferation. So this is the peak was divided. This is a completely very well proliferated healthy donors in the young adult patient. However, elderly patient can only divide 1 time, or elderly septic patient has not divided well. So this means impaired proliferation of CD4 T cells in a severe septic patient was observed in the elderly patient. So we can find the T cell exhaustion with impaired activation, IL-2 production, and proliferations. So next, how it affects the secondary infection in these patients, and how the long-term outcomes. So we think that all the culture systems, and every 3 or 4 days we took the sputum and the blood and the urine, we check again, and how the bacteria was occurred. So when the sepsis was occurred, so all the patients have some kind of the positive culture. So it's normally same in the elderly and adult patients. However, in 2 weeks and 4 weeks after sepsis, there is no positive cultures in a young septic patient. It means young patient can kill the host bacteria in the body. However, elderly patient still has some kind of the pathogen in the body, so it could causing some secondary infections. And finally, this is the survival curve. The first 7 days will be same in a young and adult elderly septic patient. Some patient is really severe with septic shock and lose their lives. However, the young patient will not die after 7 days after sepsis. However, in acute, semi-acute phase, elderly patients are losing and dying into their almost 30 days. So decreased survival with delayed death was observed in the severe sepsis in the elderly patient. So summary, T-cell exhaustion may be associated with increased secondary infection following to decreased survival in the septic elderly patient. So however, when conducting the immunological studies in this patient, we are thinking distinguish individual aging and immunosenescence, how to create the impact of immunosenescence. So actually, some of the reviewers suggested me to conduct the Cox proportional hazard regression models to find the impact of factors on the survivors. So we did finally find that age is the most strong predictor in these models. However, it's not imperfect. It's not perfect. So we focus on the hematopoietic stem cell. So this is a product of all kinds of the blood cell types. All the cell type comes from these cells. So young people has very well balanced with the lymphocyte and the myelocyte. However, elderly patient has maybe changed the populations and the balances. So we do see what is happened in the elderly patient. So we have exchanged whole the blood in the young and aged mice. So we used the two types of the mice. One is the young, one is the adult. We have irradiated lethally and exchanged whole the blood. So we made the 4 types of the blood. So young hematopoietic stem cell to the elderly mice and young hematopoiesis to the young mice. We conduct the blood exchange and do the CLP sepsis models after the perfect transplantation in 2 months, 3 months. And what has happened in these 2 groups? So actually, I expected the elderly hematopoietic stem cell will lose the population of the HS, lose the numbers. However, it slightly increased. However, the balance has changed. Aged BM transplanted mice had lower rate of the common lymphoid progenitor, which is the source of the lymphocyte, and increased ratio of the myeloid progenitor CMPs. And so aging causes a skewed differentiation from the HSCs. So we also checked how this skewed distribution changed CD8 T cells. So we found decreased absolute population of CD4 T cells in spleen in aged BM transplanted mice. And we found that impaired T cell activation in CD4 and CD8 T cells in aged BM transplanted mice. And we also find impaired production of interferon gamma, which kills viruses or infected cells. So these kind of changes will induce impaired adaptive immunity in the elderly. So finally, we conduct a survival study in these models. We conduct a CLP model and what happens. It's so interesting. There are mice who were transplanted young HSC with a higher survival like that. However, when the young mice transplanted in the aged HSCs will reduce the survivors. And so in the aged mice, young BM transplantation will enhance its survivors. So we divided the young host and the aged host. So aging of the HSC will convert these survivors like that. So it's kind of the Dracula stories. You know that it's a European famous hoax. So Dracula, a vampire, will kill the young ladies and took the blood from the young. It may change, reverse, and impaired immunity by aging and reverse it to be young. So the summary of this study, so age-related skewed shift lymphocyte to myelocyte where reduction of the immunocompetent T cells and maybe cause the sepsis and the poor prognosis. So conclusion, aged hematopoietic stem cell may demonstrate the unbalanced lymphocyte to myeloid shift leading to impaired production of the immunocompetent T cells with high mortality after sepsis. Thank you so much for your attention.